recently completed a randomized control trial that was comparing seeds to wires in patients with node-negative breast cancer. All patients received a magnetic tracer for sentinel lymph node biopsy to challenge how we move forward, and also to challenge a concern that I had detected among colleagues, that co-administrating the paramagnetic seed and the SPIO in the same area would kind of affect the outcomes of surgery, or would lead to unnecessarily larger excision volumes. And I understand the challenge. This is something that is relevant, but that's why we went for a multi-center pragmatic trial, including units that did not necessarily have experience with the technique, where we did not put a barrier in surgeon participation. So residents were eligible operators, people that did not have any experience with the technique at all, so they could do their first case in the trial, just to kind of emulate real-world conditions in that. After some 430 patients randomized, we feel that the outcomes were very promising. We had very, very low re-excisions. Obviously, the re-excisions and the resection ratios are lower the more one is familiar to the technique. Everything worked very, very well. We had a re-excision rate across the entire trial of 2.9%, which was the exact same for the wires.
That's good.
Same resection ratios, so co-administering MAGTRACE and MAGSEED did not affect the outcomes. Sentinel lymph node detections of 99%.
That's great.
Just to address things that had to do with, again, real-world practice, which means what is the policy that facilitates healthcare providers but also improves patient experience. We had 15 or 16 surgeons involved in the trial, 6 radiologists and 5 theater coordinators that graded each and every procedure. We had a lot of good data on that suggested that going all magnetic was something preferable for everybody. And interestingly, there was one surgeon that thought that wires worked better for them. Their response was also quite honest. It is because I have been taught this way and I'm not interested in changing. Which is something that you can take into account.
Isn't that interesting? But what you've demonstrated is that by the real world approach of taking all comers, if you will, into a study and gently moving people in the direction of using more modern technologies so that we can address our patients' needs, but also deal with OR, operating room scheduling, or scheduling as you might want to call it, and take into account the concerns of all the various parties in the healthcare system, but focused on the patients. It's just great to have seen that.
We are discussing about how surgical trials contribute. When it comes to breast cancer, I think that the important surgical trials are those that can show that you can do less or do better without compromising outcomes, right? In this context, what we saw, I would not expect a magic bullet that would show much less re-excision rates or smaller specimen and things like that, because if you have a trial where you have an overall re-excision rate of 2.9%, when one sees that in the hands of experienced surgeons with the technique, we could, with the combination of the seed and the SPIO, reach 0.9 re-excision rates by removal of only 26% excess tissue.
That's great.
Yeah.
So we have pathology in theatre, so that's easy. I want to ask you, because when I teach, I always teach a lot around eras. Did you look at the time taken for whoever took the specimen to radiology and back
as
downtime? When, if you're working with seeds and everything, you cut down on your downtime, and for me that's so critical, particularly for in my life where we have large numbers of patients.
We actually had outcomes on that.
Okay, good.
Because
that's very important.
We looked prospectively in the trial into intraoperative localization failure, and in that context, the seed outperformed the wire clearly. And then again, we looked also into the time to specimen excision and time of surgery. And The combination of the seed with SPIO meant faster surgery, both in terms of excision of specimen, but also surgery as an overall procedure.
But the taking of the wire from the OR to the radiology, the specimen, to confirm that you've got it.
This did not vary because,
Okay.
I mean, this was a randomized trial, so we had to have similar procedures.
Right.
It was faster across all centers,
No doubt.
and it did not depend on surgeon experience.
It's interesting you say that, because the other experiences we're not really including in that discussion at the moment are the experiences of the imaging team that placed the seed.
Yeah. The radiologists were happy with the seed.
Yeah, I'm getting very strong feedback
Yeah.
that it's an easy placement mechanism. And then at the other end, when the specimen does reach pathology, they're not going to cut the radioactive seed in half.
Yeah.
They're not going to have trouble with spiking their fingers on reflectors or anything like that. So I think there's a lot of positives for the other members of the wider multidisciplinary team.
Yeah, and also the hours that they need to work. I'm not talking about us.